Hello, everyone, and welcome to BrainMap. This seminar series is co-sponsored by the P41 funded Center for Mesoscale Mapping, housed in the Martinos Center. It is my great pleasure to introduce our speaker today, Dr. Michael Fox. Dr. Michael Fox is the founding director of the Center for Brain Circuit Therapeutics at Brigham's and Women's Hospital, and associate professor of neurology at Harvard Medical School. He is also the inaugural Layman D. Adams Distinguished Chair of Neurology and the Kaye Family Research Director of Psychiatric Brain Stimulation. He completed a degree in electronic engineering at Ohio State University and MD and PhD at the Washington University at St. Louis, a neurology residency and movement disorder fellowship at the Mass General Brigham. Clinically, he specialized in the use of invasive and non-invasive brain stimulation for the treatment of neurological and psychiatric diseases. Dr. Fox's research focuses on developing new and improved treatment for brain diseases by understanding brain circuits and the effects of neuromodulation. His paper has been cited over 39,000 times, and he has won awards across the field of neurology, psychiatry, and brain stimulation. Honors include the.
You can cut that part. Let's get to the science. But anyway, thank you so much for the very kind introduction, and very good to be back. Very good to see people. Thank you for coming in person. Thank you for joining online for those that couldn't make it. And again, just a huge shout out and a huge thank you. I have so many collaborators here at the Martinos Center. It's really an honor to be back. It's great to see all my collaborators and friends in person. Disclosures up front, my funding sources are listed. I do have some conflicts of interest, including intellectual property on the topics I'll be discussing today. So the question that we spend a lot of time thinking about in our lab and now in our center is this question of how do we localize neuropsychiatric symptoms? How do we identify the spot or circuit in the brain that's causing a neurological or psychiatric problem? And this is something you guys think about a lot here and are pioneers on at the Martinos Center. But for us, it's not just academic, it's also clinical. What we're actually looking for is a location in the brain where we can implant deep brain stimulation electrodes, turn them on and actually make a symptom better. Or a spot in the brain where we can hold a transcranial magnetic stimulation coil, use that coil to modulate brain activity and make symptoms better. And you guys have an amazing TMS clinical treatment service here in this building. And there's a lot of approaches for this. And I'd say that the most common approach that you guys have used here at the Martinos Center, and it echoes the most common approach in neuroimaging worldwide, is neuroimaging of symptomatic patients, right? It makes perfect sense. If you want to localize a symptom, find a bunch of patients that have that symptom, put them in a scanner, and look for neuroimaging correlates of that symptom that you want to treat. But there is a downside to that approach, which is no matter how much you increase the power or complexity or technological advance of your MRI scanner, and no matter how much you increase your cohort size, in the end, you're usually looking at correlates of the symptoms you want to treat, not causes of the symptoms that you want to treat. And so let me just give you an example. That was a recent paper from our lab where Joe Taylor looked at neuroimaging correlates, specifically brain atrophy, across 193 studies and 6 psychiatric conditions. And for each one of those studies, he basically just mapped out the coordinates that were reported in that study. He then took each one of these neuroimaging coordinates and said, okay, I want to know what brain circuit those atrophy locations are actually hitting. So he took each one of these imaging studies, mapped out the coordinates from those imaging studies and said, what are they connected to? What brain circuit are they hitting? And what he found is actually there was a pretty common pattern across all of these different studies. In fact, 85% of these studies were functionally connected to a common brain circuit, right? Now, that's kind of cool, right? Across all these different studies of atrophy and all these different psychiatric conditions, those atrophy locations mapped onto a consistent brain circuit. But it doesn't tell us how we should interpret that brain circuit. So what Joe did is he then said, okay, that's kind of cool. And in fact, he's not the first one to observe this. There's a lot of very nice papers out there looking at a common neuroanatomical substrate across psychiatric disease. But the thing that Joe did different is said, okay, what happens when you lesion this circuit? Because we always assume that atrophy locations are in some way causally related to the psychiatric disease that we're imaging. But what he found is that when he looked at lesions that actually hit this same circuit that we see these atrophy sites in psychiatric disease, they actually produce very little psychiatric illness. In fact, there's a patient right there where that lesion whacked that red and yellow circuit pretty completely, and they had 0 psychiatric diagnoses after their focal brain damage. However, the patients that actually had lesions hitting the anti-correlated circuit, so as far away from these atrophy locations as you can possibly get, those were the patients that were getting diagnosed with, in this case, 8 different psychiatric illnesses after focal brain damage. And actually, he found the same kind of inversion when he looked at treatment targets. So neuroanatomical sites that we've been lesioning to treat a wide variety of psychiatric diseases for decades. Now, again, the atrophy locations map onto the red circuit, but so do our treatment sites that make psychiatric disease better, right? And so what he found is that the causal interpretation of these neuroimaging correlates of psychiatric disease might actually be the exact opposite of the way most people have been interpreting brain atrophy in psychiatric disease. So because of this gap, right, this causal issue, we've kind of pivoted away from functional neuroimaging correlates of the conditions we want to treat to focus almost exclusively on what we're calling causal sources of information for human brain mapping. And there's a finite number of them. Brain lesions are one that we're going to talk about, and then also brain stimulation sites. And so let's first focus on brain lesions. We've been using brain lesions to map out brain function and neurological and psychiatric disease for well over a century. And that's because every time there's focal brain damage, there's a causal link between the location of that damaged tissue and a new onset neurological or psychiatric symptom. And this is how lesion-based localization is supposed to work. It gets even more powerful when you go from one patient to multiple patients. So these are 3 patients, patient 1, 2, and 3, with focal brain damage and a new onset symptom. Let's just say it's depression, right? In every single one of these patients, there's a causal link between that location of damage and that new onset symptom. And you can map their locations onto a common brain atlas and see where they overlap. And that gives you a very strong causal link between that intersection of these different lesion locations and that new onset symptom. In fact, this exact analysis was done in depression in the late 70s, and that's what contributed to us using the left dorsolateral prefrontal cortex as a TMS target for depression. However, there's a problem with lesion analysis, and that's that beautiful picture I just showed very rarely happens. And in fact, when people tried to replicate that paper from the 1970s for depression, it didn't replicate. And more often than not, when you try to do lesion mapping, this is what you're left with. You take 3 patients that all had the same new onset symptom after their focal brain damage, you map the lesion locations, and they don't line up. And you're left scratching your head. Where does depression localize? Because these lesions causing depression are hitting lots of different brain regions. And this is exactly part of the problem that contributed to a decline in lesion mapping and a rise in correlative functional neuroimaging. So this is where we're going to turn to a resource called the Human Brain Connectome. I don't need to introduce this to this audience, but basically you guys have built a wiring diagram of the human brain by collaborating with lots of other people over the last few decades. And this has been a very, very powerful resource, both for mapping out anatomical connections. And we got Suzanne Haber and Anastasia Nicky sitting in the front row who can tell you much more about which of these connections are real and which one of these connections are not real. But it still gives us a proxy that we can use to understand how different human brain regions might be anatomically connected. Now, even more valuable for us has been maps of functional connectivity. These are spontaneous fluctuations in brain activity that occur as you're resting in an MRI scanner. Now, it doesn't mean that 2 areas that are fluctuating together are anatomically connected. It is a functional consequence of multiple polysynaptic connections that tell us that when this region goes up, this other region tends to go up, and vice versa. So now let's go back to our problem of lesion-based localization. There's something powerful here because each one of these lesion cases gives us a causal link between behavior and neuroanatomy. But now, rather than assume that lesions causing the same symptom will overlap one brain region, We can ask whether lesions causing the same symptom overlap a connected brain network or connected brain circuit. And we focus more on functional connectivity because we believe that the lesions causing the same symptom can be polysynaptically connected, not just anatomically connected. However, there are examples where anatomical connectivity also works, like hemiparesis after a stroke. If you hit the coracospinal tract, you're not going to be able to move well. If you hit the arcuate fasciculus, you're not going to be able to speak well. But for a lot of complex neuropsychiatric disorders like depression, these polysynaptic functional connectivity maps can be really valuable. So people have used this technique that Aaron Bowes dubbed lesion network mapping across now 40 different symptoms. There's been 50 different papers and over 8 independent groups that have used this technique. And so I just want to start by highlighting these are all lesion network mapping studies that I had nothing to do with. So other people have picked this up and used it very powerfully for mapping out a lot of cool stuff. This is the stuff that I've been involved with. So I'll highlight a couple of these studies today, but I'm happy to answer questions about any of these neurological or psychiatric symptoms. And so I introduced the idea that we can use lesions to map depression. And so that's one of the first things that we tried, but it was hard. It actually took almost 500 lesions across 5 different data sets for us to get a signal. Now, that's not surprising. Depression is a complex, heterogeneous disorder. You wouldn't expect everybody's depression to look the same, so you wouldn't expect every lesion causing depression to be the same. And what Jaya Padmanabhan did is first she combined all these data sets and found about 60 cases where there was clear new onset depression after focal brain damage. And she found around 300 cases that had no sign of depression after the focal brain damage. And the first thing she did is just use traditional lesion mapping to say, is there any spot in the brain that when lesioned is statistically linked to new onset depression? And she got a giant goose egg. And this was even using a priori regions of interest in the dorsolateral prefrontal cortex. However, when Jaya looked at what each one of these lesion locations was connected to and repeated the analysis, she got a very clear answer, which is lesion locations causing depression were way more likely to be connected to the left dorsolateral prefrontal cortex. Now, what that means is we can go to this red spot in the left prefrontal cortex, look at what it is connected to, and by definition, that's giving us a polysynaptic network that when lesioned is more likely to cause depression. So you can see that, yes, lesions hitting the left dorsolateral prefrontal cortex, lit up there in yellow, they're more likely to cause depression. But so are lesions to the parietal cortex and the right prefrontal cortex, even areas in the cerebellum. In fact, there's also areas that you see there in green that when lesioned might be protective against depression. But you need to look at things from a circuit perspective to begin to understand how lesions might cause a given symptom. And we think this is therapeutically relevant. When you take this lesion-based depression circuit and map it onto the surface of the brain, you get a map of areas that you might want to stimulate with something like TMS to make depression better. And those 3 dots there are actually 3 different trials where they use TMS to treat post-stroke depression and had positive outcomes. And you can see all 3 of those sites are falling nicely within this depression circuit. I'm going to pivot to another example, which is addiction remission. So most of these neurological and psychiatric lesion-induced symptoms that I have listed here, getting a stroke was a bad thing. But every once in a while, you can get a stroke and it's a good thing. So every one of these cases was addicted to nicotine at the time that they had a focal stroke. And all of them immediately lost their addiction when they had a stroke. And I don't mean they followed their doctor's advice and stopped smoking after they had a stroke. I mean, they immediately lost all craving for nicotine, no withdrawal symptoms, never returned to smoking. And in fact, this observation was a very nice science paper in the late 90s by Nakvi et al., showing that lesions that hit the insula were more likely to get rid of addiction than lesions in other brain areas. What Nakvi didn't highlight in that science paper was that the vast majority of lesions that got rid of addiction didn't hit the insula. And most lesions that hit the insula didn't actually get rid of addiction. So there must be something else going on here. And so we resurrected this data set from Iowa and combined it with another data set from Rochester. And then just like we did for depression, the first thing we did is map out all these lesion locations very carefully and say, is there any spot in the brain that when lesioned is statistically linked to loss of addiction? Again, just like depression, we came up with a giant goose egg, and this included a priori regions of interest in the insula. However, when we turned each one of those lesions into a brain circuit, a map of what that lesion is connected to, and repeated the analysis, we got a very robust result. In other words, lesions that get rid of addiction need to be positively connected to areas like the insula, also the anterior cingulate, but they also be negatively connected to areas like the medial prefrontal cortex or the hippocampus. And so again, there's a connectivity profile, a circuit topography that's a better predictor of whether a lesion will get rid of addiction than just looking at brain regions and neuroanatomy itself. Now, this one was kind of cool because these are therapeutic lesions that led to a therapeutic outcome. So now we can play a game where we can say, okay, if this is exactly the connectivity profile of a lesion that gets rid of addiction, let's go through the brain on a voxel by voxel basis and identify what spot in the brain best matches this lesion connectivity profile. And on the top row there, those are the spots in the brain that have the ideal connectivity profile for a lesion getting rid of addiction. And so if I wanted to go to our surgeons and say, hey, let's go ahead and burn a hole to get rid of addiction, then actually I would do it right here in the paracingulate gyrus. Turns out that's very close to the anterior cingulotomy site that actually has been used to treat addiction. And then there's a second target. Again, it's just in the far anterior insula. It's actually into the frontal operculum, which seems to have the ideal connectivity profile of a lesion that gets rid of addiction. But we can also play the opposite game. We can say, okay, in the top row here, those are the voxels that have the ideal connectivity profile for getting rid of addiction. What voxels show exactly the opposite connectivity profile? Well, now that would be a horrible spot to lesion. And that's what you see here in the frontal polar cortex. I'd predict that a lesion there would definitely not get rid of addiction, but that might be an ideal spot to administer excitatory brain stimulation with a technique like TMS. In fact, when we mapped out the electric field model of the FDA-approved TMS coil for treating addiction, that's what you see here in green. And that was very surprising to us because this coil was intentionally engineered to penetrate down to the insula based on that old Knock-V science paper. But even though they built this coil to try and target the insula, the peak site of the electric field in this coil just turned out to be in the frontal polar cortex, exactly where our lesion data suggests you might want to stimulate to try and make addiction better. That's a really good place for me to pivot away from brain lesions to brain stimulation. So I told you before that there's a finite set of causal sources of information for mapping out symptoms, and brain lesions are one and a classic one. But each time we administer TMS or each time we turn on a DBS electrode, there's also a causal link between the location that stimulation is administered and the resulting behavioral change. So let's look at DBS, for example. So these are all patients that had deep brain stimulation electrodes implanted for treatment of Parkinson's disease. And even though the surgeons were targeting the subthalamic nucleus, which is shown there, kind of that dotted white outline shown in yellow, there was natural variability in where those electrodes ended up. And because there's a little bit of patient-to-patient variability, and because we have people like Andreas Horn that can map that variability very precisely, we could look at the stimulation site in each subject, look at what it was connected to, and identify connections that co-vary with improvement in Parkinson's symptoms. And Andy was able to show that that works across different data sets and across different surgeons and different centers. Again, everybody had their electrode implanted very close to or in the subthalamic nucleus, but exactly what they were connected to seemed to predict how much better they got. And Andy's really gone crazy. In fact, invented a whole new field that we call DBS connectomics or connectivity guided DBS. And he literally wrote the textbook on this. But here's a nice review paper where Andy illustrated all the different disorders where he's looked at variability in DBS electrode location and mapped that variability onto brain circuits associated with symptom improvement. And I'd say his story for mapping out a circuit for DBS-induced improvement in OCD is really a beautiful set of research that I encourage you to read about or listen to if you ever have Andy as your guest lecturer. But I'm going to focus a little bit more on TMS. And again, just like there's natural variability in our lesion locations and our DBS electrode sites, there's variability in our TMS administered stimulation sites. So going on right now in this building are 3 patients that are getting clinical TMS for the treatment of depression. But because we still target TMS based on scalp measurements, both at the Brigham and at the General here, there's some variability in where we administer the stimulation. And just like we did for DBS, we can map out what those stim sites are connected to understand what circuit we need to stimulate to get patients better. Now, in this case, we actually had an a priori hypothesis sitting around from the old days of TMS, suggesting that TMS might make people better because of connectivity between their cortical stimulation site and the limbic system deeper in the brain. And so we were able to test that hypothesis, and we actually tested it prospectively. And sure enough, the more connected your stim site was to the limbic system, the better you did. And unbeknownst to us, this same study was going on in Australia at the same time, and they found the same thing. The more connected your stimulation site was to this limbic area, the better you did. Now that sets up this idea of, okay, if you need to be connected to the limbic system to make TMS, or for TMS to make your depression better, can we actually individualize this? Because unlike lesion patients and brain stimulation patients, we have an opportunity to scan them before they ever get stimulated. And in fact, that's what we're doing at the Brigham. That's what you guys are doing here, is collecting individualized resting state connectivity on these patients and saying, okay, we know what you need to be connected to. Where is this patient's connectivity profile to the limbic system? And you can get a map on the surface of the brain of a personalized target, shown here in red, in the little blue dot, of what we would predict would be their ideal stimulation site based on their ideal or their individualized pattern of brain connectivity. Now, in this case, we still looked retrospectively. We didn't stim that site. We just said, okay, where did we stimulate in black based on our scalp measurements? And does the proximity of their actual stimulation site to their theoretical ideal personalized stimulation site, does that covary with depression improvement? And that's what we've seen, and many other people have seen as well. In fact, this has been reproduced now about 3 or 4 times. So we think this is a real finding. And in fact, Nolan Williams at Stanford, even before we showed that we could replicate it across these 3 or 4 data sets, say, hey, this just sounds like a good idea. I'm going to go for it. So he mapped out that individualized target and then whacked it every hour on the hour for 10 sessions per day for an entire week, and saw very rapid improvement in depression and response and remission levels that were much better than what we had seen with more conventional TMS. And that led to a new FDA approval. He calls it SAINT. And it's actually, from the imaging side, kind of cool, because this is our first FDA approval for a fMRI guided treatment or for a circuit guided treatment, in this case for treatment of depression. Now, what we don't know is whether that personalized targeting to their individual resting state target is actually necessary. He didn't include an arm that had scalp-based targeting. So we don't know what pieces of this SAINT therapy are really most important, but I think it is kind of cool that we've got an FDA-approved treatment that targets an individualized resting state circuit. Sean Siddiqui's kind of tried to take this in a more of a data-driven approach and said, okay, let me map out just the incidental variability in the TMS site across different patients. I'm going to see what each patient's stimulation site is connected to. In this case, we're going back to using the normative connectome, but you can do the same thing using individualized functional connectivity. And then we're going to just examine what connections co-vary with improvement in depression or improvement in each individual symptom of depression. So what you see here is these are the connections you need to hit to improve decreased interest. There's a different set of connections you need to hit to improve feelings of failure, and a really different set of connections you need to hit to improve trouble with sleep. But when Sean mapped out all these individual symptoms of depression, what you notice is that the same topography kept showing up, right? These are the set of connections you need to hit to improve sadness or anhedonia or decrease concentration. It was a different set of connections you need to hit to improve interest in sex, sleep, indecisiveness. And in fact, you could cluster these circuits in a data-driven way and say, okay, how many different symptom-specific circuits are there? And what he found is there are really 2. And for lack of better terminology, we called one the dysphoric cluster and one the angiosomatic cluster. So 2 different sets of connections that you need to hit to improve 2 different clusters of depression symptoms. And with this data-driven approach can actually be kind of a cool way to dissect out very complex heterogeneous disorders like depression, like Parkinson's disease, like OCD. And it also gives us ways to take this forward. So if we think Sean's right, and there's two different circuit targets for different symptoms of depression, we can identify key nodes of those circuits on the surface of the brain and say, okay, if we want to make dysphoric symptoms of depression better, we'd want to hit that red target right there. If we want to make anxiosomatic symptoms of depression better, we want to hit the purple target. And so we actually have a randomized controlled trial going on right now where people are randomized. Everybody has depression and anxiety, and they're randomized to circuit A or circuit B to see, can we selectively modulate different symptoms of depression based on what circuit we're targeting. Again, in DBS for Parkinson's disease, we've been doing this for 2 decades, but this is kind of a new idea in the field of psychiatry, or at least in the field of TMS. And I showed you a little bit on brain lesions. I showed you a little bit on brain stimulation, but the really cool part of causal circuit mapping comes when you start to combine these different causal sources of information. Because you can say, okay, well, if we map out depression based on lesions, and we map out depression based on DBS, and we map out depression based on TMS, what's the actual depression circuit? And that's what Sean wanted to figure out. So he actually put together 5 data sets of lesions, 4 data sets of TMS, 5 data sets of DBS, and said, okay, let me map out a depression circuit based on lesion locations. Let me map out a depression circuit based on variability in TMS sites. And let me map out a depression circuit based on variability in DBS sites. And these were actually very different DBS cohorts. So some of the patients were Parkinson's disease patients, where depression can be a side effect of turning that electrode on in the subthalamic nucleus. Other patients were epilepsy patients. Again, depression can be a side effect of epilepsy DBS, but other ones were actually patients with depression. As part of a trial, they had DBS electrodes implanted to try and make their depression better. And this is what Sean saw, is that when you mapped out what does your lesion need to be connected to cause depression, you get the map on the left. What does your TMS site need to be connected to make depression better? You get the map in the middle. And what does your DBS site need to be connected to make depression worse? But again, this was to modulate depression in either direction. You get the map on the right. And what he found is that when you mapped out depression based on these 3 independent causal sources of information, you got the same circuit. Now, we've been able to take this to other data sets and say, okay, if we're converging on a brain circuit for depression, can we start to move to other data sets like multiple sclerosis lesions and play the same game? So now that we think we know where the depression circuit is, can we map out lesion locations and lesion connectivity in MS and say, what does an MS lesion need to be connected to cause depression? Again, this is using functional connectivity with white matter lesions. This isn't supposed to work, but it actually mapped out pretty nicely. Now, it's not identical, but there was significant circuit similarity between our depression circuit mapped based on stroke lesions and a depression circuit mapped based on MS lesions. And so we actually think lesion network mapping in the field of multiple sclerosis is actually going to be kind of a fun thing.
I mean, both the 3 methods used to get the depression circuit, and then for the MS.
Yeah.
You say they're similar. They're similar because there's no part of the brain that's not involved.
Yeah, great question. And so what I'm showing here is completely unthresholded maps. And that's not something we're used to in functional neuroimaging, right? It's usually got to do a FWE correction and find just the little spots that survive FWE correction, and then those are the spots we care about. But this is a slightly different approach. And so it's looking at a completely unthresholded map. So we could play the FW game and get a few spots here. And in fact, when you play that game with the lesions, you get that spot in the left dorsolateral prefrontal cortex that I showed earlier. But an interesting thing is to look at the map completely unthresholded. And now what you're doing is you're looking at the full topography of every connection and its association with depression, independent of whether it survived multiple correction comparison or not. And then your statistical test is not actually correcting across different voxels. It's just saying, are these circuit topographies similar to one another if I just permute my data? If I randomly mix up whose depression score goes with whose lesion and whose DBS site and whose TMS site, how often do I get maps that match up this well? And the answer is not very often. So you're right, it's an unthresholded circuit topography that covers the entire brain, but that doesn't bias us towards seeing similarity between these different data sets as long as we permute the data. And I'm going to give you one last example of what we're doing with this convergent causal mapping, which is coming out soon in JAMA Neurology on epilepsy. And so Fred Schaefer put together 5 different data sets of lesions that either caused epilepsy or did not cause epilepsy. And again, seizures are a common complication after you have a focal stroke, but they're also a complication of brain tumors, penetrating head trauma, and multiple other lesion etiologies. And so he mapped out a whole lot of lesion locations that in the end led to epilepsy and a whole lot of lesion locations that did not, mapped out the connectivity profiles and said, okay, which connections, and you'll like this one, are statistically associated with epilepsy after FW correction. And you get just these little blue spots here. So if your lesion is connected to these areas in the cerebellum and basal ganglia, you're much more likely to develop post-stroke epilepsy. He could then play the same game with DBS electrodes and say, okay, let me examine patients that had DBS implanted in the thalamus to try and make epilepsy better. What does their stimulation site need to be connected to make epilepsy better? And does that look anything like some of these connections that our lesions need to be connected to cause epilepsy in the first place? And what he found was very similar topography, but the sign was inverted, which kind of makes sense, right? We think of DBS as a lesion that is now making epilepsy better. It should have the opposite connectivity profile of a stroke that causes epilepsy in the first place. Again, it's just another example of how we're trying to take different causal sources of information and test whether they converge on a common brain circuit to localize different neurological or psychiatric symptoms. So I'm going to leave you with 3 conclusions, and I intentionally left a lot of time because for me, the most fun for coming and giving a talk now that we're in person is actually the discussion and the caveats and the confounds. So conclusion number 1, lesions and brain stimulation sites provide causal links to human neuroanatomy. Conclusion number 2 is that the human connectome, this resource that you so nicely built for us, can be used to link lesion and stimulation sites to brain circuits. And the conclusion number 3 is that these brain circuits, we think, can then be used as therapeutic targets to improve our neuromodulation treatments. So I try to acknowledge, people from my lab and center as we went along, but I really want to highlight my worldwide network of collaborators, some of whom are sitting in this room. We wouldn't get anywhere without the connectome. So huge thanks to you, especially Randy Buckner. It's actually his GSB Superstruct project that we use for all of our lesion network mapping and connectivity analyses, but also everybody that contributes these data sets, these lesion, TMS, and DBS data sets, these causal sources of information are super valuable. And we've been lucky that our collaborators have been so generous in sharing their data. And then just to plug, we're building this unique thing that we call the Center for Brain Circuit Therapeutics over at Brigham, but collaborating with a ton of people over at the General. And really, it's a collection of faculty that say, yeah, we think this idea of mapping things onto brain circuits and then using those brain circuits to improve our DBS, TMS, and focus ultrasound services is kind of a cool idea. And so we've got a really valuable set of neurologists, psychiatrists, neurosurgeons, and radiologists kind of all working together to try and move this forward. And at this point, I'd like to take any questions.